Well, Dilawar's getting started. I'll just mention this has always been sort of a controversial subject, especially here in the Northwest, where we more or less teach one another that our climate doesn't breed much uh, significant mold and that most Northwest lifetime residents are not allergic to mold. Varies in different parts of the country depending, on warmth and humidity. But we'll hear what Dilawar's got to say. I take it you're there, Dilawar.
Thanks,
Oh, no.
Glenn. Can everyone hear me okay?
Yeah, speak up a little.
Sure. Is that better?
Yeah.
Okay. All right.
All right. So
So
let's go ahead and get started.
excellent. So we're going to talk about mold and allergy this morning. My only conflict of interest disclosure is I've served on the ad board for Blueprint Medicines, but that should be related to this topic. So our learning objectives are review the role of mold in allergic disease, review the controversy surrounding black mold and mycotoxins, and then review the current evidence for mold allergen immunotherapy. So I think before we start, we should talk about the different ways in which mold can be described and classified. So there's fungi and there's mold, and although the two terms are used interchangeably, they actually mean different things. So fungi are eukaryotic. They have cell walls typically made of chitin and have no chlorophyll. So this distinguishes them from plants in that they must obtain their energy from other organic substances as opposed to generate it from sunlight. Historically, fungi were considered part of the plant kingdom, but as we've learned more about them, they're their own separate kingdom now. This includes mold, yeast, and mushrooms. So fungi include molds, and all molds are fungi, but not all fungi are molds, because you have the yeast and mushrooms as well. The term mold is used to typically describe hyphal and spore-forming small fungi. And these small fungi are often multicellular, and they thrive in damp and humid surroundings. Fungi can impact human health in a number of ways, so not just allergy. So you have infectious diseases. This is most commonly seen in people with compromised immunity, like HIV patients, for example, or patients that have undergone chemotherapy or transplant. They can get systemic mycoses. Non-infectious disease, so this is us and allergy, different hypersensitivity, but in the case of fungi also includes a lot of pulmonary diseases that you can get, like farmer's lung, for example. Microbiome effects, so barrier function, training the immune system. So there's been increasing focus on the fungal flora of the gut and skin barrier and whether this plays a role in training immunity and other aspects of the immune system, similar to the way bacteria does, but a lot more research needs to be done in that area. And then environmental impact. So fungi play a very big role in ecology, and they can both destroy wildlife as well as help them flourish. One example of this is bats. So there are fungi that can increase bat death and harm the bat population. And when this happens, actually, it really impacts farming because the bats eat a lot of insects and other critters that typically feed on crops. And so when you have a decrease in bats, it can actually be difficult to farm in some parts of the world. And it's estimated that you can lose up to 50% of your yield in some parts of the world where farmers will rely on bats to feed on insects and other things that would harm their crop. So complex classification, the reason I want to mention this is that this plays a role in how we think about allergy and how things are closely related and how we might even guess at cross-reactivity when it comes to selecting species for allergen immunotherapy. So the things that are important here are taxonomy and phylogeny. So taxonomy is based on similarities and differences that are observed between species, often their structure, what characteristics they have, physical characteristics they might have. Phylogeny is based on the evolutionary relationship. And as our understanding of genetics increases, we're able to better classify fungi in terms of which fungi arose from which previous fungi and where these branches may diverge. So Lee et al. Not too long ago looked at 290 genes from over 1,600 species of fungi. And this is just one aspect of the work that they did on the right here, this graph here. And so they tried to group these based on taxonomy and phylogeny after analyzing these genes. They were able to break it down into these different species that are closely related. And so you can see here a lot of the ones that we might consider for immunotherapy and test. And we'll get more into this later, but one of the things that's really held back mold allergy and understanding of mold and using it in immunotherapy is estimating cross-reactivity between species and knowing which mold to select if a patient is polysensitized. And this is something that, as our understanding from a phylogenetic standpoint increases, we might be able to better do in the future. So fungal products in the environment. So the other thing that's really challenging for mold is it's just not one constant organism. They can reproduce sexually, asexually. They can be a spore or they can be hyphal. This is from a wonderful paper written by some of our German colleagues on Alternaria. And this is a picture of Alternaria in its different forms. So you can see hyphal forms and spore forms both. And so when you think about what goes into an allergen extract, is it, the mold form, spore form of the species? Is it the hyphal form of the species? Is it when it's producing sexually or asexually? So there's a lot of considerations for a species that rapidly changes during its life cycle. And so the other thing that I want to highlight here, which you really can't see in this picture, is that the products that are potentially used in the extract can include a lot of things. So the cell wall components and metabolic products. So you have ergosterol, beta-glucans, mycotoxins. Some of these we can measure in blood and other things. But when it comes to think about what do I include in my allergen extract, you got to think about what part of the species. With pets, we think about, saliva versus dander and other parts of the animal. For molds, we don't always think about, what aspect of the mold is included in our immunotherapy. So these are some important areas in which you may find mold. It's broken down by species and the source. Again, this is from our German colleagues who have written a lot of literature on this. So Cladosporidium, for example, is an outdoor mold typically found around vegetation. Aspergillus, you can find this on damp plaster, which is why sometimes, it can be found indoors. Of course, Aspergillus is a big family of species. And other Aspergillus species can be found in cellulose-containing materials where the moisture is actually only slightly increased. Fumigatus is the one that we often talk about in a variety of healthcare settings. So composting, rotting of plant material. And then for Penicillium, another one that's often tested, perishable foods, waste, wallpaper, and house dust. So sometimes mold can be found in places where you might find other allergens as well. Stachybotrys, which is one of the most infamous species that people talk about, and we'll get into that more later. Very moist cellulose-containing building materials. So often in buildings, you can find this black mold growing. So let's talk about mold and allergy, starting with this slide. So we're going to try and break this down by allergic condition and the data supporting the role of mold in that allergic condition. So, as allergists, we see a lot of rhinitis and rhinoconjunctivitis. This is one of the main diagnoses we see. So what's the evidence that mold plays a role in this? So atopic patients, as you probably are all aware, are often polysensitized. And that polysensitization includes more than just pollen, dust mites, and pets. Often patients can demonstrate sensitization to molds as well. But as we all know, sensitization doesn't imply clinical allergy. The strongest evidence for mold is actually found outdoors. So Alternaria and Cladosporidium are the best studied when it comes to the relationship to mold and allergy. But indoor dampness and mold exposure has been associated with rhinitis in epidemiological studies. So when these patients fill out questionnaires and you follow them over time and you see who develops rhinitis, whether it's a ICD code or a clinical diagnosis by a physician requiring positive testing to support it, you often find that many of these patients are sensitized to mold in their allergen profile. This table here is from a wonderful study actually done in 2003. And in this study, they took some of their patients that tested positive to Alternaria and Cladosporidium and actually did conjunctival challenges. And they looked at what's the patient's total IgE. This is 7 patients here in this table. What is their IgE to Alternaria and Cladosporidium, their skin prick test, and then did a conjunctival challenge where a score of 5 or greater is considered a positive reaction. And you can see for many patients that are sensitized on skin prick test or on IgE, that they did have a positive conjunctival challenge. Often when we think about rhinitis and rhinoconjunctivitis, we don't often have a nasal or conjunctival challenge to go along with our test results because it's hard to do in routine clinical practice. But I think that data like this does support that, again, small number of patients, but it does support that, in some patients that, the sensitization is clinically significant and they will have reproducible symptoms when exposed to the allergen. Now, in this study,
Dilawar,
though,
Dilawar, do they have a control group of people who were not didn't have IgE? Make sure this just wasn't an irritant in the conjunctiva.
yes. I didn't show the control group here, but it did include 40 patients total, and they basically only found that 7 of the patients, were willing to do the challenge. They weren't able to test everyone, but they did have some healthy controls tested, and that's why they decided that threshold of score of 5 or greater. And they did look at other allergens like grass pollen as well to help determine the score. So this is a meta-analysis done in 2013, and what this group looked at is, of all the studies that have been published purporting a role of mold in rhinitis and rhinoconjunctivitis, which of these studies will show a potential, increased odds risk positive association. And it's a number of studies here you can see listed. And so this is the overall findings, and this is broken down by different exposures. So they looked at if someone reports seeing mold in their home, if someone reports dampness or moisture in this home, if someone reports smelling mold in their home, is there increased risk of having allergic rhinitis or rhinoconjunctivitis? And you can see that that while there are a few studies that cross one here, the majority do support an association. Again, correlation doesn't imply causation, but you have further evidence here that there's a potential link. This is a study that was done in Korea. The reason I like this is because it's a pediatric allergy study. And what they looked at is children who had positive reactions to mold allergens and found that positive reactions using the skin or blood test were most likely to have symptoms of rhino or rhinoconjunctivitis compared to other patients in their cohort. So they started with 4,000 first grade students. They had them take the Isaac Standard Questionnaire, which is a validated questionnaire in this setting. They looked at patients who then had a skin prick test and had a blood test. And then they looked at, based on the questionnaire, if they had symptoms of rhinitis or not. They also further categorized them as having rhinoconjunctivitis versus just rhinitis. This is a pictographic representation of their findings. So sensitization to one or more allergens among the 16 arrow allergens that they tested. So they had a lot of people sensitized to various allergens. They looked at molds only, so a small number of patients compared to the total. And then they looked at people that were mold plus other allergens. And then, of course, folks with no sensitization. And so they did find that this small group here that was sensitized to mold only, 49 patients, was more likely to have symptoms of rhinitis or rhinoconjunctivitis, even compared to other groups sensitized to other allergens that were not mold. And they followed these patients for a number of years and used a validated questionnaire and had skin prick and blood testing. So a pretty good study overall. So chronic rhinosinusitis, that's another condition that many of us see in the clinic. What's the relationship with mold and CRS? So as this group knows, CRS is characterized by chronic inflammation of the nasal mucosa and paranasal sinuses, and we often group it as with polyps or without polyps. And fungi can actually be found in the nose and sinuses in nearly all CRS patients. But this is also true, as Len astutely asked earlier, in control patients as well. So their presence alone doesn't necessarily suggest disease, but they do see them in the nose and sinuses of both healthy and diseased patients. A Cochrane 2018 review looked at, whether or not use of antifungals can be helpful for patients with CRS. And essentially, garbage in and garbage out. They noted that there was a lot of very low quality studies, and it wasn't clear if using topical or systemic antifungals would impact patient outcomes in any meaningful way. They did note, though, that there was a lack of studies looking at AFRS, allergic fungal rhinosinusitis. And so that's the condition I wanted to briefly talk about next. We could have an entire presentation on AFS, allergic fungal sinusitis. There are a number of diagnostic criteria proposed in the literature. The Bent and Kuhn criteria is probably the most strict and most commonly used in the research setting. But you need a positive fungal histology or culture, evidence of type 1 hypersensitivity based on serology or skin test, allergic or eosinophilic mucin, radiographic findings of CRS. So this is often the stringy, thick mucus that we talk about when we're discussing AFS in clinic, nasal polyps, and in their study, Vincent Kuhn called it allergic fungal sinusitis or AFS. And so in this condition, hypersensitivity to mold is thought to play a role, but whether targeting this with immunotherapy or systemic or topical antifungals makes a difference is still actually a matter of some debate. So mold and allergy and asthma. So this is a condition that many of us see, as do pulmonology and primary care and many other specialties and physician types. So in a birth cohort study by Raponen et al., they found that exposure during infancy to 3 mold species common to water-damaged buildings was associated with childhood asthma development at age 7. And this is one of many birth cohort studies looking at this. But essentially what they found is if you have early life exposure to mold in infancy, that you are at increased risk of being diagnosed with asthma later in childhood. In the US, up to 80% of patients with confirmed asthma, so this is based on not just the diagnosis, but spirometry findings as well, have positivity to 1 or more fungi. So definitely you see an association with asthma and positive testing to mold. In Portugal and Spain, patients with increased allergic respiratory symptoms have been shown specifically to have positive skin testing to Alternaria or Cladosporidium. Again, these are the 2 that are most closely linked to allergic disease, including asthma. And then type 2 asthma has been shown in studies of the microbiome to be associated with a specific mycobiome signature. So if you look at the fungal flora of these patients that they grow from their gut, there is a specific signature associated with type 2 high asthma, again, suggesting that fungi may play a role in type 2 hypersensitivity. So Alternaria is one that I want to place special attention to because in many ways this is the best argument for thinking about including mold in the treatments that we offer as allergists to patients. So Alternaria sensitivity is a risk factor for many things, including development of asthma, persistence of asthma, and severity of asthma. When you look at the prevalence of sensitization of Alternaria in patients with asthma, it's been found to be increased globally. So for example, in Greece, 23.5% of their asthmatics show sensitization to Alternaria, 20% in Spain, and 13% in the United States. So this is something that shows up quite a bit in patients with asthma, and is associated with a number of outcomes that I think patients and allergists, physicians both care about. The other thing that's interesting is Alternaria sensitivity has been shown to be a predictor for epidemic thunderstorm-related asthma. So this is when patients have life-threatening exacerbations in the setting of a thunderstorm, and the thought is that when these storms come in, the aeroallergen burden significantly increases acutely, and that patient inhales that and has basically a large allergen challenge. And what these studies have shown is that both grass pollen and Alternaria are present, and patients inhale this, and if they're sensitized to both, the risk of developing epidemic thunderstorm-related asthma exacerbation, and in some cases even fatality, and ER visit accessing emergency services for their asthma is significantly higher. So ABPA, so this is almost a subcategory of asthma in some ways. This is another condition that some of us see, but probably not as frequently as was seen in the past. So the diagnostic criteria for this, I think, are important to define. Essentially what you're looking for is coughing, shortness of breath, worsening asthma symptoms overall, in some cases hemoptysis, and thick mucus leading to mucus adhesions. And this is often due to type 1 and type 3 immunity combination of these factors, and it's to inhaled aspergillus and its components. So when we're talking about the diagnostic criteria, it's going to include a lot of these things, but what you're looking for are diagnosis of asthma, does not actually need to be severe. Classically, we're taught it's severe, but mild and moderate patients can have evidence of ABPA as well. a fumigatus specific IgE greater than 0.35, serum total Ig greater than 500. This cutoff is often debated. Some studies say 417, some say 1,000, but the revised criteria for this condition have now suggested a level of 500. And then two of the following features. So IgG greater than 27 to A. fumigatus. Again, I mentioned type 1 and type 3 hypersensitivity here as contributing to pathogenesis. So it's not just IgE response, but IgG response as well. Bronchiectasis on CT chest, that's a classic finding, and eosinophil count greater than 500. So you need all of these plus two of these to diagnose ABPA, and these are the revised criteria that have been looked at by the American Thoracic Society and published over the last 3 to 4 years in various papers. The paper I cite here from 2021 is the group that initially proposed this updated and modified criteria, and now this has been adopted and recommended by the ATS. And so this is what you're looking for. And in this specific condition, it is an immune response to Aspergillus and its components that is causing the disease process. So atopic dermatitis, another condition that we frequently see, also of course seen by dermatologists and primary care as well. So epidemiologic studies have shown a link between atopic dermatitis and moisture damage as well as mold exposure. So there is some evidence that the two might be associated. And then various fungi are frequently isolated from skin lesions in patients affected by AD. So Malassezia pityrosporum, this is one that we often end up treating clinically as well, but this has been shown to be found in lesions of AD patients. Candida albicans, common skin floral species, but there might be unique types associated with atopic dermatitis. Cryptococcus species on the skin as well. Again, we're not talking about immunocompromised patients here. We're talking about atopic derm patients here. And specific IgE to fungi found in AD lesions have also actually been described in literature. So not just isolating these in culture, but also finding the specific IgE to these fungi in those same lesions as well. And so this is a summary of mold and allergy, and so fungi associated with hypersensitivity diseases. I tried to focus on the ones that we treat as allergists, so allergic rhinitis and asthma, ABPA, allergic fungal sinusitis, atopic derm, but there are other things associated as well. We didn't get into a detailed review of hypersensitivity pneumonitis, but this is things like farmer's lung, for example. A variety of mold species have been described in this. And then I didn't get into fungal skin infections, but that is considered to be hypersensitivity disease in some of these dermatophytoses. Trichophyton, epidermin, glaucosum are some of the species that have been described. And so you can see that in a number of hypersensitivity conditions, there is a potential role that mold plays. When I think about what's the most relevant for us as allergists, based on the evidence that I've seen so far and what we can actually treat, the ones I tend to focus on are Alternaria, Cladosporium, and Aspergillus. And that's just based on our current understanding. Hopefully this list grows and changes as our understanding of mold and disease increases over time. But when you think about where is the evidence to potentially support intervening and treating and testing these patients, it's probably best for these three molds. I also include penicillium
Dilawar,
here.
let me ask you a question. So you've been pulling studies, understandably, from all over the world, but in this region here, we've traditionally taught one another that most of these molds are outdoor soil molds, unless you have, a really catastrophic flooding or something indoors, and that you need a warm, hot, humid outside climate to really breed these molds. So is there a way to regionalize this information? How much of it is true in the Pacific Northwest?
So the best studies we have on that, which I'll get into later in the presentation as well, is when you look at labs that are sent specimens for patients to be tested for mold hypersensitivity, and you can look at the number of samples sent compared to the positivity rate for various molds. And actually, the Pacific Northwest is lower than other regions, but the percentage of samples that test positive for an IgE to any of the mold on a given panel is about 7%. And I'll share that paper with you guys. It's another slide here in this presentation. But some of our patients up to 7% of samples sent to LabCorp from this region, for example, do have a positive IgE test to a mold. So it's definitely lower than other regions of the country in the Pacific Northwest, but there are a significant number of patients that do sensitization. Even in our own clinic here at UW, we have patients that have tested positive and are on mold immunotherapy. So I think that it's definitely less prevalent here, but not absent.
I think you have to ask yourself how many of those people lived elsewhere, became sensitized elsewhere, and then brought their sensitization with them, but it still was not clinically relevant here, even though they tested positive.
I think that, with indoor species, which again don't have as good evidence as the outdoor species, some of them could be related phylogenetically and taxonomically to some of those outdoor species. And as we'll get into in a little bit, we don't know how to estimate cross-reactivity. It could be that some of these patients that are sensitized in other places are exposed to cross-reactive species indoors here. But that is a big jump, and we don't have the data yet to support that. But there are definitely means by which, it could be relevant, but I think probably less relevant in this region compared to others.
Okay, fair enough.
So I did want to talk about black mold and Stachybotrys because this comes up a lot in referrals to the allergy clinic. So what is this controversy based on? So there is a geographic cluster of hemosiderosis or acute pulmonary hemorrhage in infants that occurred in the 1990s in Cleveland, Ohio. So this is where this controversy arose from. And based on epidemiologic evidence of severe water damage from flooding, thought being resulting in fungal indoor growth in the homes of these patients, the illness was believed to be caused by mycotoxins from inhaled Stachybotrys. And this study, this paper, this report was actually retracted and has been the source of a lot of controversy. But this is where the black mold first entered the social consciousness. And why this continued to be an issue? There's a lot of misinformation out there, of course, in the digital age, but also this is an area where there's a lot of money to be made by individuals. This has spawned an entire industry of testing and mold removal from homes, various treatments and tests offered to patients. And also it is something for which home insurance and our legal system often get involved. People sue for this to try and get this remediated or moved from their home. They get accommodations for this in a variety of settings. And the evidence to really support that this is an issue, is minimal at best. And the report that, first suggested a severe outcome in children was retracted. And so the CDC actually had two expert panels to look at this. And what the panel found was that the sampling of cases in control homes was differed and not standardized. There was no case definition of disease presented in the report, which makes it difficult to classify as who has a definitive case and who doesn't. And it was skewed by some high outlying values in some patients. They also found that idiopathic pulmonary hemosiderosis was not really consistent in this setting with how they saw it in other settings. And they thought the acute onset, limited danger, and absence of iron deficiency really made them question, did these patients actually have, idiopathic pulmonary hemosiderosis or some other condition? And so for all of these factors, they felt the data wasn't there to support that Stachybotrys is the cause of pulmonary hemorrhage in infants. And based on this work, the original study was retracted. But I still see to this day referrals for black mold and mold toxic exposure evaluation referred to our clinic. So mycotoxins is the other thing that comes up in this black mold controversy. So mycotoxins from indoor molds can be found in low concentrations in house dust and bioaerosols. So this is definitely true. We have scientific studies showing this from Germany and other countries in the United Kingdom. So they're present there, but at very low concentrations. And what I thought was interesting is the concentration of mycotoxins found in food is actually 100 to 1,000 times greater than what is found in house dust and bioaerosols. I have seen some of these patients that come in for concern for mycotoxin exposure and are seeking treatment for this. And one of the things that I try to discuss with them is, the amount you're breathing in is minuscule and probably unlikely to cause disease. You actually ingest a lot more in the foods that you eat. And so when you get a blood test or urine test that shows you have mycotoxins present, that's probably more reflective of the food that you're eating as opposed to what you're being exposed to or through your respiratory tract. And so, this belief that inhaled mycotoxins cause disease is unfounded in really most cases. What is interesting, though, is mycotoxicosis has been shown to be a veterinary disease. And this is often from large farm animals consuming contaminated feed. In these patients, the concentrations of mycotoxins can get quite high because some of them consume a lot of feed throughout the day and over weeks and months, and that can actually cause issues. So it's a veterinary disease. The evidence is there for that, but the evidence in humans is minimal at best. The exception of this, of course, is mushroom poisoning, and so that is an example of mycotoxicosis affecting humans. There's definitely mushrooms out there we should not be consuming, and so that is one example I do discuss with patients. That okay, yes, these can cause problems in some conditions, but again, inhaling the mycotoxins is not your main route of exposure, and the amount you're exposed through from inhalation as compared to food consumption is very, very, very low. And of course, as is often the case with vague and subjective symptoms, they're typically not due to one underlying cause, such as mycotoxins. And then testing for these toxins, so IgG to molds, urinary mycotoxins, are not validated. It's often a waste of time and money for patients. Testing for mold spores in the home may be of limited value. The reason I say may be of limited value is I don't think it really helps you in the case of mycotoxin exposure causing vague and subjective symptoms or in respiratory tract disease because the amount you inhale is so small. But I do find it potentially helpful in the case of a patient, getting testing inside their home and outside their home. Because if there's a difference in the species in the home or in a particular room in the home compared to what is outdoor, and you can correlate it with their clinical history, say they have more symptoms in their basement or another area, then potentially there's a mold species there for you to better target. But again, that is taking a bit of a stretch there, but it allows a comparison. So relative comparison outdoor to indoor could be helpful potentially in some clinical situations. But if you tell me there's mold spores in your home, I would say, okay, that's true for most of us. So the amount of mycotoxin again inhaled is very, very small and unlikely to cause disease. So what about moisture and dampness? So in some of the epidemiologic studies I showed you folks, moisture and dampness, independent of whether a patient sees or smells mold, is associated with adverse health outcomes like rhinitis and asthma. And so what are the effects of moisture and dampness, and why would this potentially play a role in those conditions? So this is from the National Academy of Sciences. You can find it on the CDC website. And it's a very nice summary of what moisture and water damage can do. So you have your external and internal sources of water or moisture damage, and then this leads to accident or breakdown of one or more elements, and then that in turn can cause excessive indoor dampness, so pipe bursts, for example, or construction's going on and something gets damaged. And then once you have this dampness, you have an enhanced environment for other allergenic exposure, so dust mites and cockroaches do well with increased indoor dampness. You, of course, have enhanced growth of mold and other microbial agents, and then dampness-related degradation of building materials and furnishings. So you have a chemical exposure or a organic exposure that's not from a living organism that can cause, lung injury, for example, if levels get high enough. So I have seen patients with construction or remodeling inhale a large amount of dust and then have persistent pulmonary symptoms and issues afterwards. And so dampness, independent of mold, through enhancing other allergens and causing you to inhale other things you probably don't want to inhale, can have an impact. And again, epidemiologic studies have shown that moisture dampness is associated with increased respiratory symptoms. So this is something that I thought was helpful. It was published in JACI in Practice in 2016. This is a questionnaire that you can essentially give patients to assess for mold and dampness exposure. It's a validated questionnaire. People have used this and screened positive and gone home to the homes of patients and found, evidence of mold growth. The idea behind this is that we don't want to attribute all of a patient's issues and symptoms to mold, but certainly there's a possibility that mold and dampness can contribute to adverse health outcomes. So if a patient screens positive, maybe it's worth, checking their home, or for them hiring somebody to clean their home and have the mold removed. And again, this is not trying to validate, patients' belief about mold causing all their problems, but it is an acknowledgement that mold and dampness can be associated with adverse health outcomes, and that in general, removal of those things from the home may benefit an individual's health. And so using a structured questionnaire and then giving recommendations for, home cleaning and removal of, mold and reducing the dampness in a home that can be helpful to patients and as a general health measure. And so having a validated questionnaire to screen patients and potentially intervene with environmental modification could be helpful. And so focus is on prevention and cleaning. This is from the CDC website. This is what they recommend for prevention and removal of mold. Of course, always be careful when working with bleach or other ammonia-based cleaners, because it can produce a gas that's noxious and can cause you many issues. Make sure to wear appropriate gloves and masking. And then, of course, find the source of the moisture and dampness, because often it can be from leakage or a damaged pipe, for example. And then, of course, we want to make sure the home is cleaned promptly and dried out. So prevention and cleaning is where I think the focus should be when it comes to mold exposure in the home, because we don't know everything. That's why our field continues to evolve, and why we learn more about the conditions that we treat each day. And so I think it is important to try and meet the patient somewhere. Again, I'm not saying you need to validate that all their symptoms are due to a mold allergy or mold toxicity, or recommend unfounded studies, but certainly there's a possibility that mold and dampness can have adverse health effects, and that preventing that and cleaning that as a general measure for human health could be beneficial. All right, so this talk is mold and allergy. So I presented, the roles in which fungi may play a role in allergic disease, but I also wanted to focus on fungal allergen extracts. And so it is quite interesting how allergen extracts are produced. And fungi in particular are very challenging for manufacturers. So you often start with a source material. These cultures are obtained from specific companies and groups that grow mold for various applications. Cultivate that fungus. You harvest the raw materials. This includes spores and myceliums and potentially growth medium, if there's things within the medium that you want to extract. You extract the allergens, but sometimes you get things you don't want, like non-allergenic molecules, cell debris, contaminants, and toxins. You have a purification process, because we don't want to poison patients with their extracts. And then quality control. A lot of this is internal, and we don't know all the measures that a given manufacturer or company may use. But then that produces the extracts that are used for, diagnosis, such as skin prick testing, therapy, as is the case of immunotherapy, and of course in the research setting, as we try to better characterize and understand what's going on. As you all know, mold is a non-standardized extract, and that's because there's many factors that can affect its composition. No two manufacturers use the same strain, culture conditions, or harvesting and processing methods. And that's why between two manufacturers, the same extract, even if it has the same label, can be very different. And then there's a paucity of knowledge about specific fungal allergens. So it's hard to say, well, there's 90% of this relevant allergen in this extract. Like in the case of cat, for example, we know FeLD1 plays a very big role. And so if you focus on, the amount of FeLD1 in an extract, that can provide you a means for standardization, and then you have a better idea of what your patient is actually clinically receiving. In the case of fungal allergen, because we just don't know what are the specific fungal allergens, fungal extracts are typically labeled weight to volume, and this has to do with the extraction ratio. So for example, a 1 to 10 designates 1 gram of raw material extracted in 10 mLs of fluid. I put this figure up here because this is all the ways in which fungal extract production can go wrong. So you can start with, a wide mix of raw material, which is going to affect what you can extract. During the cultivation process, you can have variances in medium, temperature, exposure to light, the amount of time that things are grown. The harvesting process can be different between manufacturers. When you extract, you can use different techniques, and those techniques can have different variables. And so the amount of time, temperature, and the buffer solution, all of these can affect your yield from extraction. And then the purification can be different between manufacturers, as are the quality control measures and storage of extracts. So no standardization, high variability, that can lead to poor quality fungal allergen extracts. So there's a lot of limitations in the way these extracts are produced. So it can be very challenging to know what you're actually testing and treating a patient. So what are the challenges? I've hit on many of them with the extract production. So what are the current challenges in diagnosis? So the actual species and number of fungi to which a patient exposed to is unknown. We've only actually classified a small number of fungal species compared to the total number out there. And so we often don't know, am I testing a patient to all the clinically relevant fungi, because we just don't know all the total fungi that they're exposed to. The diagnostic extracts we have are only available for a small number of species. There's high variability. Again, this is due to a variety of things. You could start with a different raw material, and then all these different factors during the manufacturing process of the extracts can vary, causing a lot of variability. And then sensitization comes as Ig binding to multiple fungal extracts, leaving open the question of true pathogenic species. So I've actually seen this clinically, where a patient will test positive to multiple fungi, and you're left wondering, which is the most relevant one? What should I treat my patient to? Should I treat them all of them or none of them? And so our testing can also, lead to a lot of diagnostic questions. And so what are the things that we're doing to try and figure this out? So Latovsky et al. Combined phylogenetic data on fungi with the results of a large study on indoor fungi present in US homes. And they did this for a vast database of 8 million real-world results, and testing the fungi as a specific IgE to patients that was sent to a lab in the US to try and characterize, is the positivity we're seeing in the population correlating with how closely related the fungi are. And what they found was cross-reactivity rather than co-sensitization is what causes you to test positive to multiple fungi. And so this is a heat map. My understanding of this is probably a lot less than many of our colleagues in research, like Matt Altman. But essentially, this heat map shows that when you look at patients that test positive to multiple fungi and you try and break it down by the phylogenetic relationship, I showed you this figure earlier in the beginning of the presentation, you can see that there's a stronger correlation and prediction of what a patient tests positive to based to how closely related the fungi are phylogenetically. And so this suggests that when a patient tests positive to species that are very closely related, genetically speaking, and evolutionarily speaking, that the positivity is due to cross-reactivity from closely related species. When you look at the same data just based on co-exposure, you don't see as strong of a relationship. And so that's why this group concluded that their data supports cross-reactivity as opposed to co-sensitization. And then this is fungal sensitization across the United States. The dots are using a 0.35 cutoff. The yellow squares, diamonds, are using a 0.1 cutoff. And then this is the positivity to various species. And in this study, you can see that a significant number of patient samples are testing positive. So this was done by Kwong et al., and they looked at specific serum IgE to 17 fungal species from LabCorp for patients tested between 2014 and 2019. And what they found is of over 7 million samples were positive in 1.6 million patients. Oh, sorry, specific IgE, not samples, were positive in 1.6 million patients. So a lot of multi-positive patients here. So 22% positivity, 13% positive to more than 2 fungal allergens. So if you test a patient, many folks are going to be positive. And so the last thing I wanted to cover, the argument for considering immunotherapy, I think is best displayed by our studies on Alternaria. So Alternaria alternata has a dominant allergen that has been characterized in the literature, Alt-A1, and this explains sensitization in about 90% of cases. So when you try to take patients that are sensitized to Alternaria and break it down and see what is the common thing they're sensitized to, Alt-A1 is the thing that comes up 90% of the time. And as I mentioned before, it's a potent outdoor aeroallergen worldwide, and there are multiple studies linking it to allergic and asthma disease across the world. And then the efficacy and safety of AIT with Alternaria has been shown in several clinical trials, actually. Most of these admittedly have been done in Europe, but the data is out there. It has been studied. And that's because we have that Alt-A1 characteristic. So this is a German study, and what they've looked at is symptom scores in these patients. They have broken down an analysis of other studies that look at Alternaria immunotherapy. Some of these studies, interesting, included SLIT. I've never done mold SLIT or seen mold SLIT done, but some people have. Many of them include subcutaneous immunotherapy. They did provide the dosages, the age range, so children and adults, duration of therapy, 1 to 3 years, and efficacy, so symptom scores, medication scores, immunological change, IgG4 versus IgE ratio. And what they found is that for Alternaria, that there does seem to be reduced symptoms, reduced medication uses, decrease in specific IgE, and increase in IgG4. When you look at AIT to other molds, though, the data is very poor. The only other thing we have is cladosporium. And in this study, you do find that patients have some immunologic change, but that there's a high rate of allergic reaction. And these were double-blind placebo-controlled trials that were done. And some of these patients received cladosporium. And these patients, unfortunately, had a higher rate of anaphylaxis. And so cladosporium therapy, while potentially effective, seems to be higher risk. And this is what has been highlighted in the same analysis. So the previous was, what are the other studies? And then this is the patients that had a reaction. So general reaction of 81% is quite high, and 100% in the
Dilawar, again, back even in that one Alternaria study, were there control groups, placebo groups?
Not in all the studies. So most of these were a retrospective review, but some of them did include double-blind placebo-controlled trials, but not in all of them. But I think the thing that makes me more apt to believe some of these studies is that, they showed, the clinical potential as well as the immunologic change. So, the way immunotherapy works, we still need to learn a lot more about it. But one of the things I often look for is there a decreased IgE over time and an increase in IgG4, suggestive of immunoregulation. And, that's present with Alternaria Alt-1 treatment at least. And so, it's not perfect data. And sure, there's still many questions to answer, but I do think it makes a stronger argument for Alternaria specifically.
Okay.
So allergic fungal sinusitis is the last thing I wanted to hit on, because sometimes people do talk about immunotherapy for this condition. So 3 studies looking at SCIT and 1 looking at sublingual in these patients have been reported. These studies include cross-sectional, retrospective chart review, and case series, so no randomized control trials. And then small sample size with conflicting results. All studies were also conducted postoperatively, and so it wasn't clear if benefit was due to surgery or to AIT or a combination of both. And basically what this data tells me is that surgical intervention is still the cornerstone here, and that really allergen immunotherapy is unproven in this condition. All right, so just to finish up here, natural and ubiquitous part of our environment. You can't avoid mold, it's all around us, can affect human health in various ways. I think there is growing evidence that mold plays a role in respiratory allergy, but there's still a lot to define and study. And then there's insufficient evidence that mold exposure causes vague and subjective symptoms. So these are black mold patients that seek evaluation. And that the current diagnostic methods have a lot of limitation, but our understanding of mold and sensitization patterns and their phylogenetic relationships hopefully will improve this over time. And that if you're going to treat something, the best evidence is for Alternaria. And don't forget about, prevention and cleaning, because that is a good measure for general health, independent of, allergen immunotherapy and the question of, what role does mold play in allergy. So that's everything I wanted to cover today. Any other questions that anyone has? Any feedback is appreciated. And, the word of the day is allergy.
Dilawar, thanks very much. This is a difficult topic because so much of it is poorly studied or something we know much less about than other inhalant allergens. I'd just like to comment, this whole story about Stachybotrys really is junk science and has led to a lot of fear unnecessarily, a lot of litigation unnecessarily. There is a whole industry of people making money off of bad science here. There's a guy named Shoemaker who's coined a disease called, I don't know if you came across this, chronic immune response syndrome, vague and non-specific symptoms, and has created a whole other world of bad science if you come across that, just for those of you who don't deal with this very much. I don't know, did you come across that in your review?
Yeah, so I've seen this syndrome mentioned by other experts in the field, and it's something that I've seen come up in talks from allergists in Florida. I'm not sure where this Shoemaker gentleman is located or not, but I think with all the water damage that occurs there, this is an issue that's frequently brought up by patients in Florida, and so it is definitely something that people have described. And when I think of immune response syndrome or systemic immune response syndrome or SIRS, I'm thinking of sepsis or a patient, that's acutely ill in the ICU or ER, and potentially proceeding towards shock and needs antibiotics. I'm not thinking of somebody in the outpatient setting that is having a variety of symptoms that people are trying to link to mold. So I do agree it's given a rise to an entire industry around this stuff that's been retracted. Nobody ever reads the retraction. They just look at the initial report and it validates what they think and believe, and they want to stick with that. And so it's a real challenge when these patients are referred because they're insistent that they have a disease and then mold is the problem. And they're seeking some sort of treatment for that. And I always worry when patients are advised to have ports placed or go to on systemic antifungals. Azoles and amphotericin are very toxic if used incorrectly. And some of these patients put on immunomodulatory agents for their systemic immune response, and there's a lot of potential harm occurring.
Yeah, this guy Shoemaker is in Maryland, and he's actually had his license taken away. Um, he has a colleague that he trained who is, of all places, in Roswell, New Mexico, which seems oddly weird since that's the location of most space aliens. But in any event, there's a whole industry of embarrassingly bad medicine that's generated about this. There's something in the chat here from Karen.
Any comments about aspergillus ABPA and allergen immunotherapy? To my knowledge, nobody regularly performs allergen immunotherapy to aspergillus in the setting of ABPA. It's not recommended by most expert panels, although they do cite that there's a lack of evidence to support that recommendation. I would say from my perspective as an allergist, we do know that when you start immunotherapy, there's an initial increase in IgE before you have that conversion of IgE downtrending and IgG4 increasing. And ABPA is a condition where an increase in IgE is associated with exacerbations. And so I would worry about the safety of AIT, especially in the early phases of aspergillus and ABPA. And so I think you have the potential to cause harm, at least when initiating therapy. And so because of that potential concern, my practice has not been to offer immunotherapy to those patients. And I think that's in line with most expert opinion and general recommendations, but it's something that I think people have more historically avoided and we don't have a lot of actual studies on. But if anyone's aware of any studies on that topic, please let me know.
Other questions for Dilawar? My only comment would be we have a guy coming over here in February in person from Hollister Steer. The talk on that day is about venom production, venom immunotherapy, but I can send him an email to make a couple of comments about how Hollister Steer makes mold extracts and see if he can give us any credible science or standardization about their products in this area.
Yeah, that would be interesting to see what they can share. I know a lot of that stuff is considered proprietary, but whatever they can share would be interesting.
Yeah, I mean, that makes it even harder to evaluate therapy, that you don't really know what you're injecting into people.
And then I think, unless anyone has any other questions, the last thing I wanted to say is, as many of you know, I'll be leaving UW Medicine soon. My last day at University of Washington is March 21st, so it's been my privilege to be part of this community and to be invited back to give talks in the teaching series. So I appreciate having been part of the allergy community here, and I definitely learned a lot from working with all of you and listening to all the talks in the teaching series. So appreciate that.
Well,